Okay, we're going to have to restart our presentations for those who were present at the first initial introduction. I have apologies to make. Just ignore the sounds in the background. So once again, thank you, Dr. Etienne, and thank you, Dr. Velíšek. Thank you all that came here in person for this presentation and discussion. I want to especially thank Dr. Kate Moran and Karl Palad and Naftali Stern, as well as two medical students who participated in preparing this presentation, but had a conflict of activities and could not be here tonight. It is Harumi Hanakawa and Roth, Melanie Roth, okay? My name is Dr. Klepacz. I got a little shaken by this initial incident. I'm gonna be okay. And today's presentation is called Breaking the Color Code in a Healthcare System. And our purpose and goals of this presentation is not to tell you everything that you need to know about that, but raise your awareness, introduce you to a few facts from the past, and to make you focus on what's going on today in the healthcare system, and help you to engage in a dialogue and maybe making changes for your future practice. And those changes have to start happening now. So our objectives are for the participants to learn the history of color code in medicine. You will gain the awareness of current color code practices in medical field, and hopefully you will learn how to be comfortable assessing and improving services, make not only based on the clinical needs, but you will provide these services with the cultural awareness and sensitivity. So we outline this, understanding the past is the first part, and I'm going to start in a few words about the unethical research. Take a look at this picture. It's the original picture of Hippocrates Oath. I want you to keep that close to your heart throughout this presentation. This is the modern version of Hippocrates Oath. And you can read it now, you can read it at the end from the perspective of having a little bit more information at hand. While preparing this presentation, we were questioning the validity of this Hippocrates Oath. And so we were questioning if this Hippocrates hypocrisy, or is this a true promise that everybody who is graduating from medical school and starts working in a healthcare system really say it as he or she meant it. So I'm going to start with surgical experiments. I'm going to bring some names here. Some of you may be heard about Dr. Marion Sims, who is referred as the father of gynecology. And he became famous in his field because of the surgical experiments that he performed on enslaved women without any anesthesia, information, or consents for that. On one woman, actually, he did the same surgical procedure 30 times. The outcome was that he became proclaimed father of gynecology and left the woman disfigured with severe pain for the rest of her life and disfigurement. His surgical method was actually adopted all over the world. His another experimentation was to use the shoemaker's awl to move around the skull bones of the babies of enslaved women. In 1874, Dr. Roberts Bartholow, he had just one patient. He started treatment of Mary Rafferty, who had a lesion on her head. It was external lesion on her skin. He diagnosed her with the cancer, and he performed multiple surgical treatments that failed. He then inserted the needle into brain and gray matter and induced the responses that he was able to witness. Our patient had a seizure activities and she died the next day. He then published his results. In 1896, Dr. Arthur Wentworth performed spinal taps on 29 young children without knowledge of their parents in Boston Children's Hospital. Between years 1913 and 1951, Dr. Leo Stanley, who was a chief surgeon at San Quentin Prison, performed variety of experiments on prisoners. And his area of interest and expertise was around the male reproductive system. When you read his paper, he implanted testicles from executed prisoners into those who were alive, but he also was experimenting further by trying to implant the testicles from the animals, from the rams and boars, into the living subjects. Between 1955 and 1960, Sonoma State Hospital for Children with Cerebral Palsy, patients underwent the very painful procedures without any direct benefits. Furthermore, after the children died, their brains were exposed to biopsy without parental consent or knowledge. In 1880, in Hawaii, hospital for people with leper injected 6 girls under age of 12 with syphilis. That's the beginning of the experimentation with the syphilis. In 1895, Dr. Henry Heinemann intentionally infected 2 mentally disabled boys, ages 4 and 16, with gonorrhea. And his experiments inspired other clinicians, other physicians to continue similar research in the future. Dr. Richard Strong at Harvard in 1906 infected intentionally 24 Filipino prisoners with cholera, and he did not inform them about that. All of the subjects became ill and 13 died. In 1908, Philadelphia researchers infected 12 children with tuberculin at St. Vincent Orphanage. Keep in mind, listen very carefully, children who had no voice for themselves, and they had nobody standing behind them to actually be a voice for them. Many children suffered inflammation, lesions, and ended up with blindness. Dr. Fraser Knowles published studies about deliberately infecting orphans with molluscus contagiosum to study the disease. He published in a Journal of American Medical Association. Dr. Hideo Noguchi of Rockefeller Institute for Medical Research in Manhattan injected 146 patients, including children, with syphilis extract. And the study that became famous across the history of medicine and medical experimentation is Tuskegee syphilis experiment that actually went on for 40 years and included 399 impoverished Black males who had syphilis, and they were not aware that they are infected with the syphilis. Furthermore, when penicillin became a medication available for treatment and prevention of progression of the disease from first stage into second and tertiary syphilis, these subjects were deprived of that treatment. So I want you to take a look at this picture. And so what you see on the picture, you see a Black gentleman who is standing in a relaxed state. I think he's trusting this man, and the man is taking a blood for testing from him. In the back, you see the Black lady. Usually that was the technique used by the researchers to bring someone of the same background to create the sensation of safety and trust. Those 2 names, I'm sure you are historically very aware of, because they became a very big names for the development of the vaccine that actually saved many lives. But before they did that, actually, Thomas Francis and Jonah Salk deliberately infected patients at the multiple mental hospitals with the influenza virus by spraying the spray containing a virus into their nasal passages. The same year, and I read the paper on that, Dr. William C. Black inoculated 12-month-old baby with herpes. And he later on, the study on that one child published in a journal of pediatrics. He claimed that the parents donated that infant for his research. Another research between 1946 and 1948, including the researchers from Tuskegee study, used the prostitutes in Guatemala to infect prison inmates and also insane asylum patients, and Guatemalan soldiers with syphilis and other sexually transmitted diseases. That study actually was testing the effectiveness of penicillin and included 700 people. And the study were led by no other but Charles Cutler, who later participated in Tuskegee studies. In 2010, the United States officially extended the apologies for this research to the government and people of Guatemala. When you look at this kind face, he looks like anybody's grandpa or old uncle, and he is not. He's Dr. Albert Kligman. He was dermatologist who in 1965 received $10,000 unrestricted grant for his research. And he was going to study chemicals on behalf of Johnson & Johnson and Dow Corning companies. But he was going to report also his findings to the government, which he never actually managed to do. The substance that he was studying was testing dioxin, an active ingredient of Agent Orange. You remember from Vietnam War and chemical that was using in Vietnam. Dr. Kligman, when he first went to the prison, he looked around, and the first thing that came from his mind and his mouth was that he's not seeing human being, he is seeing yards of skin. And he was very excited about that. So almost 500, he was injecting his victims almost 500 times, 468 times, each time increasing the dose of dioxin. And all of the experiments, as I said, involve prisoners. Unfortunately, he destroyed all of the evidence except from a few. The picture of one of his research subjects, victims, survived, and that is what he did to people. Have awareness that many of the experiments were really truly sponsored by the US government. And it began as soon as in 1942 when President Roosevelt created the Biological Warfare Bureau. And multiple tests were conducted in the United States, like in September of 1950. In San Francisco area, 200 tests took place, and with involvement of US Navy, spraying different chemicals and bacteria into the fog that was drifting around the city. In 1966, new agents threw the light bulbs filled with bacteria onto the subway tracks between the 14th Street and 59th Street. That's the subway I was taking during my training. And I want to finish my part just to bring another name, which I discussed with the students today. And for those who are interested in pursuing ophthalmology in a future, Dr. Lucien Howie, I will advise that you review his papers between 1910 and 1917. Dr. Howie was a proponent of eugenics and killing people who have a hereditary eye conditions with the risk of blindness. And he was pleading to the US government tirelessly to change the laws. We were a little shaken today while reading his papers. So without further ado, I'm giving the microphone to Naftali Stern, and he's going to talk about Holocaust, which is going to be powerful and emotional for him.
Thank you, Dr. Klepacz. I'm going to be continuing the conversation with understanding the past. We're talking about the Holocaust. We'll start off with a quote from Joseph Goebbels, who was a Nazi minister of propaganda, one of the leaders of the Third Reich during World War II. He famously stated, "Our starting point is not the individual, and we do not subscribe to the view that one should feed the hungry, give drink to the thirsty, or clothe the naked. Those are not our objectives. Our objectives are entirely different. We must have a healthy people in order to prevail in the world." The German people wanted to create like a pure Aryan society called the state of Volk. I mean, only pure Germans were ideally be part of it. And what else do they found to be undesirable? They wanted to eradicate and eliminate. And here's some of the many steps they took in order to achieve their goal. They started off with the Jewish medical presence was eliminated in Nazi Germany, starting in 1935. A second program consisted of involuntary sterilizations of disabled German citizens, including Jews. It started as early as 1933 even. They did euthanasia of mostly Germans and Austrians whose lives were deemed medically unworthy of living, including the disabled and mentally ill. They conducted horrific experiments on numerous persons ranging from mixed race Afro-German children. The Jews in Auschwitz were conducted throughout this period of 1933 to 1945. And they did a medical genocide aimed to annihilate European Jewry and other undesirables. These are some of the many steps they took in order to achieve their goal throughout the Holocaust. Next is one of the most notorious and infamous physicians of the Nazi Party. His name was Dr. Joseph Mengele, M.D., Ph.D. His nickname was the Angel of Death. And in Auschwitz, he performed the daily selection duty. My grandfather was actually a prisoner in Auschwitz. And he told me about that day in spring of 1944, where he arrived with his family and cousins and extended family. And Dr. Mengele was there at the end of the line. And he was pretty much telling people, go to the right, where you can live and be an inmate, or left, and you could, and you're sent to the gas chambers to die. And over 3/4 of people arriving in Auschwitz perished in the gas chambers. And from 1943 to 1944, Mengele performed experiments on nearly 1,500 sets of imprisoned twins at Auschwitz. About 200 people survived these experiments. This is one example, the most famous one of the experiments that Dr. Mengele did in Auschwitz. On a personal note, my great aunt was experimented on him, and she couldn't have children after the war. And Mengele did not act alone. Research implicates numerous German and Austrian medical physicians and others in scientific community as participating in this unprecedented breach of ethics and humanity. And some of the most notorious experiments performed by Nazi physicians throughout World War II were exposing prisoners to high altitude, to freezing temperatures, to sulfanilamide, to the famous twin experiments, exposing them to poison, to tuberculosis, to phosphine toxic gas, doing bone, muscle, and joint transplantation, and performing involuntary sterilizations, doing artificial insemination, and exposing them to lethal amounts of seawater. Thank you. And then this is a quote by Elie Wiesel. He is a Nazi a concentration camp survivor, and he won the Nobel Peace Prize in 1986. He famously stated, "What hurts the victim the most is not the cruelty of the oppressor, but the silence of the bystander." I think that's really powerful. Okay.
Testing. Does that work? Okay. All right, thank you everyone for being here. Perhaps it goes without saying that origins of racial health inequities in the United States have their roots in slavery. Unfortunately, physicians played a role in this injustice. Transatlantic slave traders hired surgeons for the horrific Middle Passage in hopes of preserving their human cargo for maximum profit. In the slave markets of the antebellum South, physicians inspected the bodies of enslaved men, women, and children before signing certificates of soundness for buyers or sellers. And for the enslaved, insufficient diets, exhausting workloads, unsanitary housing, and the ever-present threat of violence, family separation, and sexual abuse wreaked havoc on untold numbers of lives. We're often taught that race is a biologic construct, when in fact it's societal and ecologic. And slavery put African Americans at disproportionate risk for diseases like malaria and yellow fever. Some historians have identified a dual system of healthcare for these people, one that was invasive and controlled by the slave owners, and the other that was humane and rooted in African traditions. So jumping ahead a little bit to talk more about sterilization that Naftali mentioned, unfortunately, the United States was a model for Nazi Germany with this practice. So in 1964, the North Carolina Eugenics Board recommended protection of sterilization for a 20-year-old Black woman. They deemed her feeble-minded and unable to assume responsibility for herself or her child, and without her input, her guardian signed the form. White elites with strong biases about who was fit and unfit embraced eugenics, believing that society would be improved by increased breeding of Anglo-Saxons and Nordics, and anybody who did not fit this mold, which included most immigrants, Black people, indigenous, poor whites, and people with disabilities, became targets. And more than 60,000 people were sterilized in 32 states during the 20th century. This is a pamphlet extolling the benefits of selective sterilization published by the Human Betterment League of North Carolina in 1950. So it's no coincidence that sterilization rates for Black women rose as desegregation got underway in the 1950s. Schools and hospitals were segregated by race, but integration threatened to break down Jim Crow apartheid. From 1950 to 1966, Black women were sterilized at more than 3 times the rate of white women and more than 12 times the rate of white men. And then, unfortunately, in the 1960s and 70s, new programs like federal programs like Medicaid also started funding non-consensual sterilizations. Just a few other examples. Between 1997 and 2010, unwanted sterilizations were performed on approximately 1,400 women in California prisons. Romani women, so this extends worldwide, have been sterilized unwillingly in the Czech Republic as recently as 2007. And Uyghurs, an ethnic minority in China, have been subjected to mass sterilization and other measures of extreme population control. This documentary, No Mas Bebés, tells the story of hundreds of Mexican-American women coerced into tubal ligations in the county hospital in Los Angeles in the 1970s. And I wanted to mention as well that Planned Parenthood has disavowed Margaret Sanger, the founder, for her eugenic views, and it will be a bit of a theme in what I'm going to talk about next, that they're sometimes complicated characters, and that's something we wanted to get across in this presentation, that there are some bad actors, but also well-intentioned physicians who have caused great harm and enforced these racial disparities. So I'm a psychiatry resident, and it's a bit painful to go through, but the history of psychiatry is important to talk about. So Benjamin Rush was an 18th century doctor, so also kind of a complicated character. He was a staunch abolitionist, but owned a slave. And he was one of the first people to say that mental illness had biological underpinnings, but he also held the racist belief that Black skin was a result of a mild form of leprosy. And one of his points to support this was a patient with probably vitiligo, and he advocated for skin rubbing to turn the patient white. The APA featured his image on its logo until 2015, and this is their apology on the bottom left from 2021 for its extensive role in other ways in support of structural racism. Rush's apprentice, Samuel Cartwright, created this term drapetomania, which refers to a disease making Negroes want to run away. So of course, if you're enslaved, that would be crazy to want. And Cartwright also came up with dysesthesia aethiopica, which is a disorder that supposedly explained laziness and a lack of work ethic among Black people at the same time. So instead of including their picture, I included this picture of Dr. Cheryl Willis, who chaired a year-long task force on exploring structural racism in psychiatry. So after those beginning years of the APA, prominent psychiatrists continued to pathologize and sometimes demonize African Americans, with the result that by the 1970s, schizophrenia in many ways was used to describe aggression and agitation among Black men. Numerous studies have shown that our very white profession has not done well understanding Black expressions of emotion and conflation of distress with anger, which has led to an underdiagnosis of major depression, especially in Black men, and an over-reliance on antipsychotic medications in this population. So these kinds of culturally derived misdiagnoses can explain excess rates of psychosis in ethnic minority patients. And this has also been shown in some studies that show worldwide rates of psychotic disorder are high for immigrant groups. That kind of makes you wonder if we're speaking their language and assessing them correctly. And it results in high rates of detention and adverse pathways to psychiatric care for ethnic minority patients. This book, Administrations of Lunacy, is about one of actually the largest insane asylum between 1841 and 1941 in Milledgeville, Georgia, and it includes a bunch of quotes from some of the leaders who were also involved in the precursor to the APA at the time, and kind of traces the impact of slavery and Jim Crow and Reconstruction on the modern way that we practice. And unfortunately, today, 90% of psychiatric beds are in jails and prisons, which disproportionately confine Black people. So, at one point, we've ignored the psychiatric treatment needs. At one point, we've segregated them, which I didn't get into as much. And over the last 50 years, we've really locked up this population without, whether in prisons or state hospitals, both of which have provided insufficient care. Last but not least, the psychiatry workforce remains much more white than the general population. And payment structures tend to exclude people who can't afford to pay out of pocket for services. We're kind of an outlier among specialties in terms of participating in public or private health insurance programs. And that's really an area that we need to improve in as well. So I just wanted to end on kind of more of a positive note. That was something that one of my patients told me today. He was a Black man who's really been impacted by racism in his life. And he said, there have been a lot of bad things that have happened to me, but also a lot of good people who have helped. And I think there, obviously over the centuries, there have been people who have been working against this problem. And I hope we can all be a part of that going forwards.
So by understanding the past, the common saying is that we should be learning from the past, but as we have seen now, and as we explore the present in pain medicine and cancer diagnoses, access to healthcare and prenatal care, we're still continuing the past. So the primary purpose of healthcare is to reduce overall pain and suffering, which we as clinicians have taken oaths to commit. However, the gold standard of treatment that everyone rightfully deserves is unfortunately still contingent on the color of their skin, their socioeconomic status, among other factors. And for pain medicine as a standalone specialty and as also being included in and integrated in various medical fields, it just heightens the importance of correcting, acknowledging, and recognizing those racial disparities associated with pain. And this is just a timeline that details a little bit about what we've noticed in terms of pain tolerance. And it's well documented that Black Americans have been systematically undertreated for their pain relative to white Americans. And in terms of advancements, early advancements in medicine, we owe a lot of its success to the suffering of slaves, unfortunately. Slaves who underwent painful procedures without anesthesia. A picture here below is John Brown, who is a fugitive slave who was, after escaping, was able to document his experiences under Dr. Thomas Hamilton of Georgia, a plantation owner and a physician who wanted to scientifically confirm his theory that Black people have thicker skin than white people, meaning that they might have better pain tolerance, as what he thought. And fallacies like these were presented as fact and legitimized in medical journals throughout. So this subsequently bolstered and supported racist ideology throughout time. And these sort of atrocities were seen similarly in the mothers of modern gynecology. This is a monument in Montgomery, Alabama, of three people who were under immense pain by Dr. J. Marion Sims. They underwent procedures in order to optimize their operations for vesicovaginal fistula. Anarcha, Lucy, and Betsy were three of many females who suffered immense pain under J. Marion Sims. So as clinicians, how do we play a role in who gets treated for pain and what quality of treatment should they receive? A 2016 paper from the University of Virginia formed two studies that tried to and successfully associated racial bias with false biological beliefs regarding differences between white and Black people. In study two here, study two studied first, second, third year medical students as well as residents and tried to assess what their current beliefs were about biological differences. And the ones highlighted here, that Blacks' nerve endings are less sensitive than whites, Black people's blood coagulates more quickly than whites, and Black skin is thicker than whites, were remarkably associated with racial bias and were things that were believed by these medical students and future physicians and residents as well. And this paper also was the first that provided evidence in association of biological differences and how that impacted their treatment. Many of these students endorsed that they believed in these fallacies, and at the same time, they also were more likely to endorse a lower score of pain for Black Americans versus white Americans, even though they had the same chief concern and the same level of pain. And so this unfortunately affected their treatment. And so how should we take Black pain seriously? Yes, of course. And the unfortunate thing is that not only do we study and learn about these atrocities, but it's still continuously perpetuated by implicit bias, stereotypes. The consequence of racial bias in healthcare includes the belief that specific ethnic groups are more likely to misuse pain medications. And this has resulted in underprescribing and withholding medication for Black Americans. Black patients, interestingly, were prescribed opioids for acute pain at a lower rate than white patients with matched chief concerns. This is despite their similar levels of reported pain. And lastly, in operations for joint replacement surgery, the use of regional anesthesia was less frequently used in Black patients and underinsured. And so what do we do next? How do we address racism in pain medicine? Firstly, we think about cultural competence, or a new rising term, cultural humility, which is our ability as, as clinicians to take note of the past racial atrocities that have occurred. So increasing diversity in the medical field can lead to increased cultural humility. And at the same time, understanding and following the gold standard of care for everybody using evidence-based guidelines can lead to helping everybody equally. Organizations can implement diversity and cultural competency to improve healthcare outcomes for marginalized communities, but I'd like to emphasize that we study a lot about evidence-based medicine, and that should be applied as the gold standard treatment for everybody, regardless of their skin color. Moving on to cancer diagnoses. There's racial bias in cancer diagnoses, and that includes recruitment and clinical trials, detection, treatment, end-of-life experiences, mortality, and prevention. In terms of prevention, African-American men have the highest cancer incidence in the US, and this is associated with lower income areas where there's an increased risk of cancer incidence and mortality. In terms of other types of cancers and mortality, there is an increased incidence in tobacco-related cancer mortality, as well as obesity and HIV infection. In terms of detection, Black people are more likely to be diagnosed with advanced stage disease. Black women are less likely to have screening at high-quality facilities. And despite similar self-reported colorectal cancer screening prevalence, Black people are still more likely to receive a lower quality colonoscopy. For cancer treatment, Black people are more likely to experience delays in their treatment and less likely to receive their recommended treatment. And just moving on more into the research and technology that we've seen in cancer research, only 7% of participants in clinical trials that's supported by the US FDA for approval of cancer drugs were Black, a very small percentage from 2014 to 2018. Additionally, only 1.3% of eligible African Americans were enrolled in breast, lung, prostate, and colon cancer trials. And so how could we apply these medications that are supposed to help in terms of cancer treatment to the actual proportion of people in the US? In terms of end-of-life experiences, when we address these matters, physicians offer less information about a diagnosis, prognosis, and treatments to Black patients. In terms of cultural humility, how can we provide and increase our patients' health literacy? How can we improve that in terms of discussing these difficult topics? In terms of mortality, Black people have the highest death rate and shortest survival of any racial ethnic group for most cancers. Their 5-year relative survival rate is lower in Black people than in white people for every stage of diagnosis. And I'd like to further explore our diagnostic algorithms that we use in terms of cancer detection and treatment divided by specialty. In terms of cardiology, the Society of Cardiothoracic Surgeons risk calculator for surgery increases risk score as high as 20% to Black patients, which means that less Black patients were deemed safe for surgery. In nephrology, we learned that for Black patients, they have reported higher GFR values, which suggest better kidney function and delays referrals to special care or kidney transplantation. We will further explore prenatal care and how that's affected by racial bias, as well as urology and pulmonology. I'd like to speak more about, in general, healthcare access to services. These are the types of healthcare services that we should have, and they are primary care, specialized care, emergency care, and preventive care. And what we've seen in terms of the consequences of limited access is that we've seen delayed or inadequate treatment, poor health outcomes, increased healthcare costs, and health disparities being perpetuated. Access to quality healthcare is a fundamental human right, essential for maintaining well-being and achieving optimal health outcomes. Unfortunately, racial disparities persist in accessing healthcare services, which undermines the principles of equity and social justice. We see here that firstly, the average family spends $8,200 or 11% of their family income per year on healthcare premiums as well as out-of-pocket costs. As we see here, post-Obamacare, the average annual cost for healthcare premiums in African-American households is greater, almost 20% of their average household income to bear, which it's a major cost to their family, and this takes into account income inequality and other economic challenges. And lastly, I'd like to just quickly discuss the Healthy People 2030 initiative. It's a comprehensive and ambitious effort in the US to set national health objectives and improve the well-being of individuals and communities by the year 2030. It's a continuation of their initiative that started in 1979 and includes objectives like reducing the proportion of emergency department visits and increase the proportion of adults who get recommended evidence-based preventive healthcare. Thank you.
Beautiful part of the presentation. This extends also to the provision of the prenatal care. In the interest of time, because we started late, I'm gonna just bring few facts that people, Black people, minority people, immigrants, those who are underprivileged and uninsured have a lesser access to prenatal care. Their perinatal care is also very limited. And the access to fertility treatments is also based on a financial situation and involves the disparities. This is two actually articles on famous Serena Williams. And I think her words speak for itself that there is a lot of prejudging that definitely goes on and it needs to be addressed. I think it's a very powerful statement when it comes from somebody who is Black and who has financial means to actually access the services and it's experiencing similar challenges. So just for those who are interested in digging into the issue of deeper, just be aware that there are societal factors, but also community factors, and they lead to the problems, perinatal disparities, relationship factors that affect that as well, and individual factors, and that makes it very complicated. So at the end, we went through a little bit of history, and now it's time to talk a little bit about making changes for the future in order to break the color code in a healthcare system. And we cannot do it alone. It's not for the individual, but it is as for collected society of the clinicians. And breaking that color code have to start early, maybe even before you start the medical education. Definitely it has to be focused of getting the medical education by the time you graduate and you actually, where are my slides? They're not there. Oh. Okay. Okay, then it's gonna be a freestyle. You have it. Yeah. Because I think, no, maybe he put the different presentation. Hold on. Sorry for that. But yeah, okay. Let's see, maybe he put the different presentation here. Sorry for that. Anyway, the bottom line is that when you understand the past, you see how much trauma went on and what led to the current state of affairs. And you need to approach from the trauma-informed care point of view, but also to have a deeper understanding of what the patient-centered care means. It is one of the medical students' objectives before you graduate from the medical school. And what this means in a simple words is to bring the patient into the treatment environment when the patient is a partner in creating the treatment plan, in discussing different diagnostic tests and procedures, and where you embrace the cultural background, the cultural, ethnic, spiritual, religious fabric of that person. And in order to do that, you need to get to know your patients. Our patients, and too bad the end of this presentation is not here. Our patients many times say, okay. Yeah. Okay, I see what the problem is. Our patients actually many times they say, you don't know nothing about me. You have not walked in my shoes. And as the physicians, we like, oh my God, I know everything. Why are you saying this to me? No, you do not. Show some humility, show some welcoming and respect to your patients. It's okay if the patients say you have not walked in my shoes. No, I have not. Let's have a dialogue. Let's be comfortable discussing the uncomfortable things. And this cultural humility and medical cultural humility is going to be a key component. It's going to be a foundation to changes in the future, to start anew, to provide the compassionate care for all of the people independently of their background, and to start breaking the color code. I think when you in your mind go through this presentation, which guys, you did an amazing job, and you go back to your Hippocrates oath, you should not cause any harm. You should be compassionate to the patient. You should accept the patient with all the cultural, ethnic, spiritual, holistic background. And if you only stick to that, you're going to be the best physician in the world. Before I finish, I want to tell you the story about 17-year-old Black teenage boy whose life up to this point was never easy. He was abandoned by his family. He was tossed between different family members, ended up going from one foster family to another, and then was placed in a group home. The day he came to the emergency room, he was feeling very hopeless and very sad, and he wanted to die. So I sit with this young man, and I ask him to tell me about his life. And as I'm listening, I'm like, oh my God, I feel his pain. He was never given a chance. But I'm listening to his story, and I said, look, you know, many bad things happen to you in your life, but let the past not to define you. You are smart, you're bright, you're very sweet. It's a pleasure to talk to you. Something is telling me that you like art and you have some talent when it comes to drawing, because I noticed he had a piece of paper and he drew something. And he listened very, very, very carefully. He didn't say nothing. By the time he was ready to go, he comes to my desk and he brings me a picture. He drew the red cardinal for me. And he looked at me and he said, can I give you a hug? And I'm not made from sugar. I did not throw myself with the hug on this young man. He wanted the hug. He gave me a hug. It was a sincere hug. And he looked at me and he said, you don't even know what you did for me today. And I'm like, what did I do? And he said, you gave me a hope. I almost cried, okay? And I think building the bridges and making people trust you, you don't deserve anybody to trust you. I would not trust myself. It has to be a process of rebuilding trust and also having a relationship with your patient, getting to know your patient, and have a holistic approach to your patient in a process of providing a care. I think as a clinicians, we many times feel like we privilege. Yes, we are, in a way that we have a profession that is actually a mission. It's a sacred profession. It's a sacred mission. People come to us when they have no other choice, when they are in crisis, when they are in pain, and we should not violate that trust. To the contrary, we should build on it. So I thank you all very much for your attention. And if you have any questions, Dr. Etienne and Dr. Velíšek are going to take that.
Can you all hear me? All right. Well, thank you very much for that really just amazing presentation. And it's usually not easy. Well, first I'll just introduce myself. I'm Dr. Mill Etienne, Vice Chancellor for Diversity and Inclusion here at New York Medical College.
Hi. My name is Libor Velíšek. I'm the assistant dean for the M1, M2, besides being a neuroscientist.
Yes, just thanks, Dr. Klepacz and your team, Dr. Moran and the medical students for the really just amazing presentation, very thoroughly researched. And always, I'd say it's not easy. I know people see these presentations and think people are just able to just stand up here and talk about these traumatic experiences, but oftentimes it involves re-experiencing trauma. And it's, you know, even if you didn't go through it yourself, your predecessors may have gone through it. They've made significant sacrifices. So it's not an easy thing to present this and then to talk about it afterwards. We do, for the folks in Zoom, please feel free to put a question into the Q&A. We'll be glad to take questions. Just, I don't know if you have an initial thought or question, Dr. Velíšek or anyone here.
Not a question, but I think it was a very comprehensive review of the history, and we need to go back to the history so we don't repeat it.
Yeah. Yeah, and Dr. Klepacz, the way you closed this session, one of the things that I thought of as you were speaking was the importance of this new kind of emerging field of narrative medicine, that we provide much better care for our patients when you actually understand their narrative. And a lot of that narrative for these individual patients actually happens before they were even born. Because their parents, grandparents, and others live through traumatic experiences, which are stories that are being told and retold in their households. So that is a part of the patient's narrative. It also showed a lot of the common bonds that happens across different peoples, because lots of people have suffered, and you know. And we often hear about the Holocaust. We often hear about slavery, but we're hearing about other things that you're telling us, things that have happened even after, you know, even in present day. And so I love the way you presented it as this is the past, and this is what's happening today in medicine, in healthcare, and around the country. So that was a really beautiful way to present it. And then I like the fact that we're not just gonna drop these horrific things on you, but we're going to talk about how do we move forward. You know, what are the next steps? How do we give better patient care, this trauma-informed care? So those are my initial thoughts, and I do see that there's a question in the audience from someone who I'll say is my cousin. I won't put her name out there. She probably doesn't want to. I did put a quick blast on my family chat, so it looks like they made it out. What is the best way to communicate with your physician when you feel like they are not listening or understanding what and how you're feeling, whether it's a condition or pain, etc.? We'll give it to Dr. Klepacz. Do you have an extra mic? Do you want to just maybe float around with a mic?
So for those who know me, I work in an emergency room. And I'm the front line for the people who come and they truly are in a crisis. So they are angry, frustrated. Sometimes they scream. Sometimes they fret to mess me up. Sometimes, they wanted to kill me. And I think the ability of the clinician to actually be able to absorb some of that anger, and I think what we were talking about today, understanding where people are coming from, knowing the past, helping people to embrace their own anger because they have a right to be angry. And once you withhold your own personal response to that anger and frustration, once you help the patient to own it, once you validate the patient's feelings, then you can have a dialogue, clinician and patient. And that is a part of actually trauma-informed care. Because through that, if you help the patient to embrace the anger and stay in control, own their feelings, normalize these feelings for the patient, then you create the safe space. And that safe space actually help the patient to feel comfortable to ask maybe uncomfortable questions or reveal some uncomfortable, painful information about themselves. So I hope this was
Excellent, excellent answer. And as you were answering that question, while we wait for other questions, one of the things that came up recently, I was speaking to a physician, a white physician, who was caring for a Black patient in the hospital. And I know this physician very well. She's, I would say, exceptional, puts her heart, puts 100% for every single patient she cares for. But she called me because she's taking care of this, doing everything imaginable, going way above and beyond for this young Black woman. And the patient said to her, I think I'd have better care if I had a Black doctor. And this, needless to say, this stung her, right? Because she's like, she's somebody who I would say is very, has a great deal of cultural humility. But this stung. And it made me think about, what if, I kind of talked her through it, but think about what if the patient was somebody from the LGBT community who felt, even though you're going above and beyond, you still don't fully understand me, right? And say, well, I think my care might be better if I had somebody from my community, is what the person is really saying. And, lots of data has shown, improved outcomes in patients when they have racially concordant or ethnically concordant relationships. But I'm just curious if anybody here has thoughts on that. Oh, we got somebody right here.
I actually was about to ask if I could add on to what you said. So as a science-based female Hispanic, right, I've seen this on both sides, right? Both on the side of the practitioners, because I've worked in healthcare before, and I work right now here for the college. But I've also seen it as a patient and as a relative of a patient. And that's in particular what I'm going to be discussing right now, right? So my example first, before I say anything, my family has the BRCA1 gene. And that has meant that one of my aunts has battled cancer 4 times. And in her 4th battle with it, it ended up being terminal for her. And it very much could have been prevented. Because what ended up happening was that we had a doctor who ended up taking a new job in a different city, and a different clinician took over for her care. Now, her previous doctor had told me, because my aunt does not speak English, was being taken care of by my family, and I would usually go in to basically advocate for her. And a lot of times patients don't have that, right? If they have that language barrier, that's where it comes in what you mentioned, right? You might feel more comfortable with someone who is of your own background. And in this case, it actually was reversed. The physician who took better care of her was white. and the one who replaced her was Hispanic, but Hispanic male, taking care of a Hispanic female. And unfortunately, in our culture, one of the things, it's not so much about, you know, oh, well, you're just angry or you're just this sentiment or prejudice, right? It's that, you know, Hispanic women are thought of to be hysterical, right? That we think everything is a very serious matter. But her previous physician had told us, you need to be taking a close look at her platelet count. If it goes down, you need to have them check everything. If it's good, if she keeps increasing, all is well. And at one point when they did her blood work, I noticed that the platelets had lowered. And I told the physician, can we please run some tests on her because her previous doctor had said this. He said, no, that's not necessary. Everything else was perfectly fine. I said, I hear you. I see that too. But this is what her previous physician told us. I don't think it's necessary because blah, 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 blah. And the thing is, as both patient and physician, there comes a point where you have to be able to be comfortable to say the following line, which was, if you will not run this test for her, I will seek someone who will do it for her. And whether you are a physician or as the patient, you have to realize that there comes that point where you are allowed to say, you are not listening to my needs. She could not speak for herself. She would not have known to be aware of that. And what ended up happening is that because of this, he did not schedule those exams for her until 2 months later. And by then the disease had already spread throughout her body again. And again, these are things that could be avoidable if the physician and the patient feel comfortable enough to communicate this. But in that first appointment where I noticed those platelet counts, I was not there with her. I saw it after the fact, which is why everything for me was a phone call to this man. Yeah. And again, you know, there's that point where you need to be able to have that comfort, and how do we reach that comfort level is the issue, right? Because as a patient, it takes a lot, especially if you are of color, to feel that you have that right. Sometimes it's not even told to us, especially back home where I live, right? I'm from deep South Texas. Clinicians will not tell you, you have the right to change your doctor. Yeah. It's never stated outright, but it is something that you are allowed to do.
Yeah, no, excellent points. And what I want to summarize what you said in a way that I usually kind of counsel people, which is to suspend certainty. That's on the side of both the patient and the provider, that making assumptions about each other can kind of put you into trouble. So like you just said, it's possible to get excellent care from a white physician, a Hispanic, Afro-Latina, whatever it might be. So if you just come in with assumptions that are loaded about the other person, that could actually harm the overall care on either side. But then, you know, that whole, which makes things complex. So for the provider, remember you don't know everything, right? So suspend certainty and say, maybe I should listen to this patient who's asking me to do this test. Because in this case, this provider was wrong, right? By not doing those tests that were necessary. So clearly that person did not have 100%, you know, knowledge of what needed to take place. And on the part of the patient, you just, you know, assumptions about the provider. I always say assume good intentions on both sides. And it becomes hard sometimes, especially when you've had bad things happen to you or bad things happen to your family. It's hard to approach an encounter as this person's got good intentions when you've seen, you know, we just saw the history that there have been times when even the US government has kind of put things out there that were false to patients. So, no, great, excellent points. Thank you for sharing. Yeah.
To actually ask the questions, to challenge you, and you cannot take that personally. Maybe because I'm in a business of psychiatry and emergency room, and I am lifelong interested in trauma and multi-generational trauma, historical trauma, and I just love to empower people. And I know who I am. It took me a lifelong of the journey to understand why I react to this or that, but I don't think we're teaching this in a medical school, because we are dealing with the patients who have a pain, or they are in distress, or they are very anxious about getting a diagnosis. How little we actually think about that. When I look in the emergency room, I look around. I like to say that in the past 7 years, when I moved into the main medical emergency room, I changed the culture. We are talking with the students now, how it was 7 years ago and how is it now. And I think advocating for the patients and standing in front of them and trying to ask for the service and for somebody to listen to their voice, it takes a courage. It's not supposed to be like this. I had a patient that, I went to the nurse and I said, you need to get this patient a doctor. This patient is in a distress. And I told her what I think. And she said, okay, you know what? You can step out now. I'm going to have the real doctor to take care of the patient. And if I had issues actually with my professional skills or my personal skills, maybe I took that personally, but I didn't. Okay, and I showed them over the years that all of the patients that are my patients, they don't have to have a mental illness. Why I'm saying this? Because when you know the past, you need to feel responsible for observing the present. And when somebody comes and they want to discharge somebody against the medical advice, usually it's somebody who is a person of color, minority. And hold on a second, you need to be able to be a voice for this patient. What is making you upset or frustrated? How can I be of service? Before you go, let me see what you came here for. You can save life or two. You can change the dynamic in your environment, but you have to have a courage to do that. It's not easy. But when you do that and you get used to it, you're going to see that people actually keep coming back to you. They start trusting you. They know the doctor is their advocate, their attorney, and they can trust you.
Yeah, I love what you just said, Dr. Klepacz. It actually made, as an epidemiologist, one of my other hats, was one of the first things we learn in, when you're getting your M.P.H. is to consider the counterfactual, which is also a way of suspending certainty. So if you have this negative thought about the patient or about the doctor, consider the opposite view and see, might this be true? This person who's going out against medical advice, let's flip it and see what's really going on here. And that maybe they're right, or we can both be right. It's not a zero sum. Life is not a zero sum game, right? It's both of you can be right and both of you can be wrong at the same time. So I think that's an excellent point that you've just made there. Great. Excellent. And we got a comment from the audience that says, powerful presentation, and this is a conversation that is needed, especially in healthcare.
Oh, that's amazing. I think that's very amazing. I want to thank you both for being here and for your amazing support, but also Dr. Moran and the students. And I think in the process of preparing this, we were having mini discussions like, oh, I didn't know that. Oh, that's interesting. Oh, I didn't know that. And I think what I wanted to say at the end, that because we are teaching facility, teaching institution, as a mentors and supervisors, I think we should also watch ourselves, because I feel like we are constantly watched too. And when we have a young medical students or residents that start the training, I think they pick up on our behaviors and model their behaviors on ours. And I cannot emphasize more appeal for the teachers, supervisors, and mentors to actually be aware of your power over the minds of these clinicians in training.
Yes, absolutely. I think that's one of the mantras we hear. We don't want to say, do as I say, not as I do, because we all know that students, children, any trainees are watching, and they are going to model your behavior. So we want to always be good role models. And I'm just going to put a pitch. You might be a biased pitch, but this is a session on bias, which is why are we the ones hosting this session? Why is Dr. Velíšek, Dr. Klepacz, Dr. Moran, Dr. Etienne coming together to do this? Because bias rests in the brain, and we are the specialties that we study. We have the one organ that is able to study itself, and it's able to study and understand itself. It's able to understand the world around us. So I really do personally, I think Dr. Velíšek and Klepacz, Moran all agree with me that really I feel like it's largely a big part of our responsibility is to educate people about their brains, why we have these biases, why these atrocities have been able to take place throughout our history. It's because of decisions that people have made. So really, I think we are the ones, and I would encourage really universities across the country. If you don't have your psychiatrists, neuroscientists, neurologists involved in these efforts, get them on board, because our training teaches us how to actually address these issues. I don't see any other questions. Anybody else from the audience? Final words? Quiet in the back. We want to get you to start speaking up. Oh, there's one.
Comment on the added layer of intersectionality, the fact that we all have multiple identities. You know, we have color of skin, we have our ethnicity or country of origin or ancestry of origin. And so, you know, if the patient says, I don't feel comfortable because you're not from my culture, but you know, there's all different aspects here. So, you know, a Jewish person taking care of a Muslim person, maybe they'll feel that they don't understand. But maybe if they're both women and they feel that men wouldn't understand the problem that they have, then there is that connection. I'm a gastroenterologist. I deal with a sensitive part of the body at times, and happen to be Jewish, and I happen to have a large number of Muslim women patients who trust me, I think, was a woman. Now, I don't share, you know, ethnic background of the ancestry, but I can relate on some level. Same thing with LGBT, you know, you can identify as a woman, you can identify as an LGBT woman, you can identify as a Jewish woman, Jewish LGBT woman, and you know, sometimes you have to choose, like, where does your, I don't know, what's your priority, or what, you know, where does your, I don't know, I don't say loyalty lie, or like, even like when you're voting, you know, what is the, are you gonna go with somebody who, you know, needs this identity, that identity, or the other identity? It's very confusing. It's complicated. I guess I'm just saying it's complicated, and I see it in every aspect of everything. You know, we do medicine, in politics, in the world, and how, you know, how we carry on our daily lives, and it's sort of something to think about.
Yeah. Excellent point. And we have a gastroenterologist in the audience, and I'll just say, just so you know, we consider you part of us, because there's the second brain we know is in the GI system. So you're definitely part of the club that we've got going on up here. But you raised the point about intersectionality and the importance of that, and how that has a huge impact on our decisions. And I think that's somewhat what our person who spoke earlier was alluding to, was that maybe I don't want a person who has the same ethnicity as me, but I wanted a woman physician, or I wanted somebody who's from LGBT community, or somebody who went to the same college as me, right? There's so many different identities that we all walk around with. And that's why I think what we spoke about earlier is the narrative is so important. I think the more, understanding that each patient is a universe unto themselves and saying, I need to understand that universe, right? And the more time you spend trying to understand this patient, the stronger connection you're going to have because you have more knowledge. I'm a big fan of Johari's windows, and you've got a huge blind spot and you've got a lot of unknowns, but each question you ask, you're getting to know the patient so much more, and you have to make them comfortable. You might have asked a question, they might actually lie to you because they don't feel ready to share that information until you've really made them feel comfortable. And I think with AI is out there, so I think with AI we're going to learn a lot about intersectionality because the AI is able to study such large amounts of data to understand how and why people make choices. We have a couple more from the audience, but actually we have one in person. You were going to make another comment?
Yeah.
Can you give her the mic?
So this is my 2 cents, right, on the overarching question on how to make things more accessible, both as practitioner and patient. When I was in college, one of the courses that I took was on medical anthropology. And I very strongly feel that that in particular is not known as well enough as it should be because its primary focus is on making the practitioners more aware of the cultural biases that they might hold and how they can better approach patients that are of a different background, whether it's color, religion, even just the country that you were born in, what your sexuality is, which, touches on what you mentioned as well. But these courses, and even sometimes just the seminars like this one, for example, are not mandatory at institutions where you are teaching and educating practitioners on how to be the best practitioners out there. These are always optional. There are very few institutions that I have seen, at least, where it is a requirement, the same way that you have to take Bio 101 to even get into pre-med or to even get into the grad schools. I feel at least that we are at a point where those such courses need to also be required, not optional. You come in here and these are very important topics, but we don't have a full room. And it should be a full room because we're at a medical school where every of the students that are here, every of the faculty that are here have to take these issues into account. And there should be more people here, but it's optional, right? And it comes down to that same idea. I think at least that would be one of the ways to solve these issues. I mean, not immediate, right? But something to think about.
Well, I can tell you, we're going to use our collective brain power and make this mandatory in the future. We will work with that. Dr. Velíšek is the year 1 and 2 course director. So we're going to work on that. I think I agree with you 100%. We consider this a test run. We wanted to, do a smaller scale event, but still, if we had a full house, we would have gladly accepted it. The great point. There's a comment from the Q&A that I want to share, brings a very important point and still goes with what we've been talking about. There is a movement in the endometriosis community that if you have previously gone to a practitioner who has correctly diagnosed you, made you feel unheard, recommended the incorrect treatment, once you have received the care you actually need from someone else, you should collect all your medical paperwork and send it to the former physician so they can learn. So basically, if you were diagnosed incorrectly by a prior medical provider, and somebody else gives you the correct information and diagnosis and treatment, give the prior person some knowledge so that they know that they missed the diagnosis. That does not happen too often, but it seems like there's a movement going on to make this happen. That way others do not have to go through the same experience as you. I guess that way, by making that other person aware, they can give more correct diagnoses. What it also made me think about a little bit was, I don't know if you're familiar with back in the 1930s when the Green Book came out. Anybody here familiar with the Green Book? Yep, I see somebody in the back says yes. Our gastroenterologist. We're
Good
gonna
movie.
put you up here with us. That's where you belong. The Green Book, for those of you who aren't familiar with it, was called the Negro Motorist Green Book, and it was really for when people was now starting to drive around, and Black people would basically identify places that they were able to make rest stops, whether it be a restaurant or a hotel, a motel, those types of places, so that if you went to a place that didn't make you feel right, you don't want more people to go there, right? But if you find good places that are safe, where you're not getting chased and bad things happening, it was added to the Green Book. So now this is a safe place. And I think nowadays, and this is somewhat the converse of what the audience member was saying, was that you find a good doctor, you find somebody who made you feel safe, who made you feel comfortable. You want to spread the word, right? And say, yeah, this is a good place to go. If you're from whichever community you're from, Black, Hispanic, Jewish, LGBT, women, whatever it is that your identity is that might be frequently not heard or not listened to, or even certain disease states, right? Certain medical conditions. You say, I found a doctor who's listening to me, who's gonna validate my concerns. So that's the place to go. So yeah, excellent point. More comments from the audience. Very informative and much needed conversation on a topic often swept under the rug. Thank you. All right. I think that exhausts the audience list from the Zoom. I think we're gonna end here. Any final remarks? Dr. Velíšek?
Town in Poland. When I first came to United States and started my residency, I felt uncomfortable because it was anything and everything that I have not learned. Meaning that I started coming to work at least an hour ahead of my time, before the morning runs, before going as a group to the patient's room. I needed to get to know my patients. I want to have a personal connection before 5 other interns attending and a couple of residents come first thing in the morning into the patient's room. And without saying much, they will each put their either hand or stethoscope against someone's chest, depends of the clinical condition that the patient had. And I had a beautiful adventure. I remained true to myself. I maintained my clinical style. I got to know my patients, and I was more than excited to listen to their personal stories from people from all the corners of the world. And I think as a teacher, my understanding is that I'm not telling my students or my residents what to know or what not to know. I open their eyes, I show them directions, I raise awareness, and the rest is in their hands. And that is my responsibility as a teacher. You cannot expect somebody, a physician, to actually know 100% everything that the person with the cancer is going through, unless you have a cancer. So you cannot have all of the conditions or represent all of the groups to really try to understand their problem. I think being humble, I think being generally and sincerely curious about another human being, excited about learning other cultures, language, background. I tell my patients, I want to know everything and anything about you. Take me to your family home. Bring me to your kitchen table. Show me, tell me what you're eating. I'm salivating sometimes and drooling when they talk about the food. But that's how you learn.
Yeah.
And the more you learn, you really love and embrace people independently where they're coming from. And you're excited about their culture. And you're excited about how different, but to a certain degree, we're all the same at the end of the day. We really are. So that's the message at the end. And I think
just so you know, that Dr. Vieux sends his regards. He works. Yeah, he works.
I love you, Vieux.
On that note, thanks everyone for joining us for this first session that we've had on this topic. It won't be the last. Thanks, Dr. Klepacz, for all the hard work of putting this together. Dr. Velíšek, Dr. Moran, and the students, wonderful work. Thank you. Thank you all. To be continued.